for getting care, via the internet, via retail outlets, via some type of personal health coach. I think we'll see a lot more of that. If you call that rationing, then yeah, it probably is, because there's not enough money, there's not enough clinicians to take care of all the issues that we're going to have. Yes?
One thing strong in healthcare is positive evidence, and the trouble is that they have strong evidence that the efficacy. Where are we now with that? Secondly, how does it link to the general population?
Right. Yeah. So obviously Obama is very big on comparative effectiveness, which generates the evidence. And like I said, it's extremely difficult to develop that evidence because you need to be able to follow a patient for a long period of time. And the data just is not aggregated or integrated in a way that you can say, okay, the patient started to do well, and then when this event happened, this procedure, this drug, this whatever happened to him, he started to decline or they started to improve. And it's kind of hard to see that because you know that that procedure happened, but you don't necessarily know what happened to the patient afterwards, unless they were readmitted or came back to your facility and you had that information. So being able to aggregate that data across the entire continuum of care for that patient is key to developing the evidence. And a lot of that has to be done manually right now. If you can build a comprehensive PHR, which has all the information that has happened to you from care settings, plus the fact that you've lost 50 pounds or you changed your diet or you were compliant with your medications, all those things, I think that would help you generate evidence that people would believe.
And it's right to generate national care and the issue is right by doing that.
Right. Yeah, I think so. A lot of people ask me the question of, how are we going to build this? I think what's going to be really difficult to do is to create this big aggregated database in the sky and then go scoop out, meaningful answers. I think what you're probably going to have to do is have focused, disease-specific problems to solve. So you're going to say, hey, let's go attack diabetes, all right? So we're going to create all these databases and standards and specific questions about diabetes. Build that, okay? Impact that. Answer the 5 or 10 difficult questions that really cost a lot of money in healthcare. And then, down the road, maybe we can build this huge database in the sky. But right now, we need to solve problems and save money, or we're going to run out. Did you have a question? Yeah.
There's two segments. One, disease management. Second, are they going to be a single platform, or would they be disease segment?
Wellness and what? Yes. Okay. Yeah. So, yeah, absolutely. He asked. We sort of separate right now wellness and disease management, just because if you're diseased, you're not well. Is that going to be something that's merging together as we move forward in healthcare? I think the components that do that will probably be the same thing. So the personal coach, the medical home, the specific pieces that say, hey, if you're in this state or this condition, you need to do this next. That's probably the best way to answer that question. I think wellness, disease management are going to come together in the mechanisms and the modalities which the patient gets the information. Yes.
Specific to seniors, they have lived longer until they go to retirement home. What do you consider the important consumer assistive technology that they could use?
Yeah, so a lot of that, the question was consumer assistive technologies for seniors in the home. A lot of that stuff is emerging and continues driving a lot of that. Basically, you want to have as much home monitoring as you can. Whether, it goes down to as simple as, having your diabetes, blood sugar, glucometer, report back to your medical home, to, having, physiologic monitors in the home that report back as well. So the whole idea is to identify when a patient is at a threshold or at a cliff that you want to avoid them falling off. Yes. One more question. Yes. Yeah, so the question is, typically the payments go directly to the clinician or the clinician's facility, and if you have patients at home, how do you build the payment structures specific for that type of care? And you're right, that's the only way that you're actually going to change things is by changing the payments. Financial incentives sort of drive all of this. I don't really have a good answer for how that's going to evolve right now. I think what we are seeing is that there's a lot more coming together of sort of all the parts of the healthcare setting that take care of a patient. So right now, as you all have seen your bills, when you come out of the hospital, you get billed from 50 different entities, right? And you'll get one 6 months later that you never even heard of. I think what we're going to see with the bundled payments is that there will be a coordinator of care, and those folks will sort of coordinate the various healthcare modalities that take care of folks, including the stuff at home. And if the bundled payment goes one place, then that will drive sort of the integration of business process for those folks. Well, thank you very much. Enjoyed it, and enjoy your day.